So this is the knee examination. Knee examination, the same. You start with the gait. You have to check the gait. So I already discussed gait. 20-level gait, high step gait, antalgic gait, and hemiplegic gait in this way. So you already know. Then after that, inspection of the knee. Inspection of the knee from the patient is standing from the front, side, and back. You have to check the knee. What will you see? As usual, 3S, starting from the 3S. Scar, sinus, swelling, wasting, deformity, erythema, and so on. Okay, here, wasting. Where will you see the wasting? Wasting of the quadriceps. For the knee examination, you have to check the quadriceps. In chronic case, you will see the wasting of the quadriceps. Another thing is the deformity. Deformity, here, you see, for example, the knee will be flexion deformity. Flexion deformity. The knee will be flexion deformity. And the knee will be, it is bow backward. Recovery. It is called genuine recovery. Then the knee will be out, the leg will be outwards. The leg is going outwards. It is the genuine valgus. And then the leg will go inwards. It is the genuine valgus. In this way, you have to check the wasting and deformity of the knee. That is in sitting position. Here, you check the position of the patella. In normal, patella is facing forward. So this is the normal position. Sometimes patella is going up. It is called patella alta. Sometimes patella is going down. You can compare with the normal side. Patella is going down. It is the patella bhaja. Okay, in this position, ask the patient to extend the knee, then flex the knee. So, you see the patella tracking pathway. So, the patella tracking pathway is in normal position, in central. Some patients, for example, flexion and extension, the patella is going outside. It is called the lateral dislocation of the patella. In lateral dislocation, in recurrent lateral dislocation of the patella is going outwards. So pathway, the patella pathway is going out. So now you have to check the patella pathway. Then in supine position, inspection, you check again. 3S, scar, sinus, swelling, and swell. After that, especially in lying position, you have to check the Q angle. What is Q angle? It is the line you must draw to the point of the central point of the patella, anterior superior spine. So the one line draw from the anterior superior spine to central part of the patella. One line. Another line is that here tibial tubercle, tibial tuberosity. Center part of the patella to the tibial tuberosity. Another line. Another line between the center part of the patella and tibial tuberosity. So in this way, two lines, it intersect here. So you have to measure the degree. It is a Q angle. Q angle in boys 14, girl 17. You have to measure the Q angle. So if Q angle is 40 to 70, it's more than 40 to 70, it is abnormal. Second is the palpation field starting from the temperature. In front, medially, laterally, and then back, you have to feel. And compare with the other side, normal side. This is the temperature. After that, you have to feel the tenderness. Firstly, patella. Is there any tenderness in the patella? Then after that, you flex the knee. You feel the joint line. Joint line, both medial and lateral. Joint line, medial and lateral. Joint line. Then goes backward. Then here, there is a ligament, collateral ligament. Here, medial collateral ligament, lateral collateral ligament. Then after that, posteromedially. Tenderness in the posteromedial, tenderness in the posterolateral. Then after that, popliteal fossa. In this way, you have to check the body tenderness. Repeat. Firstly, you have to feel the patella. Then you check the joint line, anteromedial, anterolateral. Then collateral ligament, then posteromedial, posterolateral. You have to check, then after that, popliteal fossa. You have to check the tenderness. After that, you have to check the extensor mechanism. Extensor mechanism means patella, then quadriceps, then patellar ligament, then tibial tuberosity. You have to check the tenderness in the quadriceps, patellar ligament, and tibial tuberosity. You have to check. So you have to check the integrity, whether it is continuous or not. Sometimes in patellar fractures there is a gap. Sometimes quadriceps muscles rupture, there is a gap. Sometimes there is a patellar tendon rupture, there is a gap. So you will feel the gap in patellar fracture, quadriceps ruptured. So you have to feel whether it is continuous or not. At the same time, you can check the mechanism, extensor mechanism, whether it is intact or not. Ask the patient to raise the lower leg in extension position. Okay, raise the leg in extension position. It means the extensor mechanism is good. If he cannot raise up, the extensor mechanism is not good, then he cannot raise up. There is a painful, there is a pain conditions here. In this way, you have to check the extensor mechanism. Okay, after that, you have to check the patella again. Patella, this is the anterior surface, smooth and no gap. Then you have to feel the posterior surface of the patella. It is the articular surface. Post medially, then feel the articular surface. Post laterally, feel the articular surface. So you have to check the posterior surface of the patella. Sometimes in osteoarthritis, patellofemoral joint osteoarthritis, there is a painful. So there is tenderness. So push medially and feel the articular surface. Push laterally, feel the articular surface, posterior surface. In this way, you have to check. Okay, after that, you have to do for the patella, you have to do the friction test. This is the, you see, press and push downward and upward. This is the patellar friction test. If there is an osteoarthritis changes, there is pain. There is pain. Any pain? No. So here, there is you press and push downward and backward. This is the patellar friction test. Okay, next, apprehension test. Apprehension test, so you push the patella. You push the patella laterally. You push the patella laterally, then up slowly, you slowly flex the knee. Okay, say again. Push the patella laterally, then slowly flex the knee. In this maneuver, if you do further flexion, the patient notice if he has the experience of the lateral dislocation of the patella, he is very reluctant to do further flexion, because with the further flexion, the patella will be dislocated laterally, very painful. He has the experience. He knows if he do further flexion, the patella will be dislocated. So he is reluctant. So he resists for the further flexion. So it is called the apprehension test. Okay, apprehension test. Here you push, patella is pushed laterally, then flex the patient, flex the knee slowly, then the patient will resist. It is the apprehension test positive. Okay, say again. So in palpation, if there is a temperature first, then tenderness, patella, joint line, and collateral ligament, then posterolateral, postomedial aspect. After that, you have to check the extensor mechanism. Quadriceps, patella ligament, and tibial tuberosity. Then you check the integrity of the extensor mechanism. Ask the patient to raise the leg in extension. In this way, you have to check the extensor mechanism. After that, you have to check the patella thoroughly. Anterior surface, then posterior surface. Then after that, you do the friction test. After that, you can do the push the patella laterally, and then you do the flexion. It is the apprehension test. Okay? Then we have to check the synovial thickening. Synovial thickening, you with your thumb and middle finger, you grab the patella. If you can feel the patella, yes, there is no synovial thickening. If you can't feel the patella, yes, there is a synovial thickening. In this way, you have to check the synovial thickening. Then after that, you have to check the knee effusion. Knee effusion, firstly, cross fluctuation test. Cross fluctuation test, we'll use the two hands. One is the suprapatellar pulse, and the other hand is on the both sides of the patellar tendon. Then this one is the tapping finger, this one is the washing. Now you squeeze in lower part. You tap here, you tap. So you wash the fluid trail in the left hand. After that, opposite maneuver, then you squeeze the upper hand and you wash in the lower hand. So in this way, this is the cross fluctuation test. Okay, next one is the patellar tap test. Patellar tap test, you empty the suprapatellar pulse. Then after that, you hold the patella and then you strike against the femoral surface. You strike against the femoral surface. You hold the patella, then you strike against the femoral surface. This is the patellar tap test. Another thing is the burst test. Burst test, you empty the suprapatellar pulse, then after that you empty the medial compartment. Now the fluids are collected in the lateral compartment. Then when you feel the medial compartment is deeper, at that time you tap from the lateral side. You tap from the lateral side. So you press from the lateral side. So the fluid comes to the medial side and the gap is filled up. So the dimple became burst. It is called burst test. Say again for effusion. First of all, cross fluctuation test. You have to use the both hand, upper hand on the suprapedalar pouch, lower hand on the side of the patellar tendon. Then here use, for example, from the lower hand you squeezed, the fluid trill goes to the upper hand. Then upper hand you squeezed, the fluid trill goes to the lower hand. In this way you can do the cross fluctuation test. Second test is the patellar tap test. So you squeeze the suprapedalar pouch, you empty the suprapedalar pouch, the fluids are collected in lower part. Now you hold the patella and you strike the patella against the femoral surface. So in this way, if there's a fluid, there's a tap, 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 you can feel it. So that is the burst test. So you empty the suprapedalar pouch, then empty the medial compartment. So the fluids now come to the lateral compartment. So lateral compartment is here. There is the fluid in the lateral compartment. Then you on the medial side now. If you remove your hand, there is a dimple on the medial compartment. Now you press on the lateral compartment, so the fluid will fill the dimple. So the dimple became burst. It is called the burst test. Okay, in knee move back, extension, flexion, internal rotation, and external rotation. That's all. Okay, next, you have to test the stability. In stability test, there are two types of the ligaments. One is the extracapsular and another is the intracapsular. So now you are testing the extracapsular ligament. So how? This is the knee, and firstly 30 degree, then 30 degree flexed, then there's here the leg is going out. So this is the valgus force. In 30 degree, you test it with the valgus force. So this is called 30 degree valgus test. Valgus stress test here. If it is positive, means the knee joint open. If 30 degree valgus stress test positive, it is due to the medial collateral ligament injury. Okay, in 30 degree, here the leg is going inside. It is called varus force. Now in 30 degree, you are doing now you apply the varus force. So it is called the 30 degree varus stress test. 30 degree varus stress test is positive, means that if the knee joint is open on the lateral side, it means there is a lateral collateral ligament injury. So firstly, varus stress test, valgus stress test. So 30 degree, here 30 degree, now 30 degree valgus stress test, the leg is going out, it is the valgus stress test. So if the knee joint is open, it is due to medial collateral ligament. Now 30 degree varus stress test, if the knee joint is open, it is positive, it is due to the lateral collateral ligament injury. Okay, then straight. In straight, here this is a valgus test, valgus stress test in straight. So straight valgus stress test. So if the knee joint is open on the medial aspect, the ligament injury is complex. So these ligament injuries are medial collateral ligament, oblique ligament, semimembranosus ligament are torn, all the complex ligaments. Okay, now in straight valgus here, the leg is going inside. So straight varus stress test. If the knee joint is open, if the straight varus stress test is positive, the injuries are lateral collateral ligament, iliotibial band injury, popliteus muscles, and arcuate ligaments are torn. Okay, I will show you again. 30 degree. Now I am doing the Vargas stress test. 30 degree Vargas stress test, it is isolated. Medial collateral ligament. Straight Vargas stress test, if it is positive, the injury are medial collateral ligaments. Oblique ligament, semi-membranous ligaments are torn. Okay, 30 degree Varus stress test. If it is positive, lateral collateral ligament. Okay, in straight position, Varus stress test. If positive, it is complex. The injury are lateral collateral ligament, iliotibial band, arcuate ligament, and popliteus muscles. Okay, fine. Here there is a table. Varus stress test. 30 degree Varus stress test. Isolate. The injury is the lateral collateral ligament injury only. In straight position, positive, it is complex injury. Lateral collateral ligament, iliotibial band, popliteus muscles, and arcuate ligament. Okay, Vargas stress test. If 30 degree positive, only medial collateral ligament. In straight, Vargas stress test is positive. It is complex. Medial collateral ligament, oblique ligament, and semi-membranous. Okay, that's all. Second is the cruciate ligament. So, cruciate ligament is an intra-articular ligament. So, to test the cruciate ligament, firstly, you flex the knee and it must be symmetrical. Here the heel, here on this side. Yes. The heel must be in the same position, same level. In this way, the heel must be like this. Then you have to check from the side. You have to see the tibial tuberosity, whether they are in the same level. If for example, the tibial tuberosity on the left side is sinking backward, it is due to the posterior cruciate ligament injury. It is called posterior sagging side. I will say again, here the heel must be symmetrical. Then you check from the side. You have to check the tibial tuberosity, whether they are the same level. For example, the left side tibial tuberosity is sinking backward. It is called the posterior sagging side. The cause is due to the posterior cruciate ligament injury. Now, after you adjust the position, then, for example, this side is abnormal disease side, left side, for example. So, now you put the position in this like this, you place the position like this, then you sit on the foot of the patient, then here you hold the upper part of the tibia, then you draw. So, you draw with the body weight. Sustain, not jump action. Sustain action, you draw. And then you will feel. If the tibia is going forward, you will feel. If this is called the anterior drawer test positive. And then this is neutral position. Then you press backward. This is the posterior drawer test. So here, this is the disease side. This is the normal side. Okay, now I will test. Here, draw anterior. This is the anterior drawer test. On the right side, normal, neutral, then post. There is a posterior drawer test. Okay, then you test on the disease side. Pull with the body weight. Now, you feel or you will see the tibia tuberosity is going forward. The tibia going translated outward. The tibia translated forward. It is called anterior drawer test positive. Cause anterior cruciate ligament injury. The neutral position, then post backward. The tibia translated backward. It is called posterior drawer test positive. Cause posterior cruciate ligament tear. Then another test is the Leishman test. It is a confirmation test for the anterior drawer test and posterior drawer test. Confirmation test for the cruciate ligaments. So you place your leg under the patient's thigh. Under the patient's thigh. You place your leg under the patient's thigh, like this. Then you hold and stabilize the femur with your hand. Then grab the upper part of the tibia. Then you can stabilize the femur with the left hand. Then grab the tibia with the right hand. Then you move forward, neutral, backward, forward, neutral, backward, forward, neutral, backward. In this way, you can maneuver. So in this way, you can do it. So this is called the Leishman test. Okay, say again. Your leg under the patient's thigh, and with one hand, stabilize the femur. Other hand grabs the upper part of the tibia. Then after that, you translate the tibia. So forward, neutral, backward. Forward, neutral, backward. In this way, if the tibia in anterior cruciate ligament injury, the tibia will go forward. The tibia will come forward, neutral. If there is a posterior cruciate injury, the tibia will go backward with your maneuver, very obviously. So if the body side is this way, so you can test the cruciate anterior drawer test, posterior drawer test, and Leishman test to confirm the intracapsular ligament injury. Now we are going to do the meniscus test. It is called McMurray test. So here, full flexion, then external rotation of the leg. Then you apply the valgus force. Full flexion, now a valgus force. So in this position, while applying the valgus position, you slowly extend the knee joint. At the same time, you feel the joint as well as you check the patient's face. If the patient's face wrinkles due to pain, or if there's a crepitus in your hand, it is positive. McMurray positive. So this maneuver is meant for the medial meniscus. Okay, say again. Full flexion and external rotation. Then apply the valgus force. While applying the valgus force, slowly extend the knee joint. At the same time, you check the joint line and patient face. patient face weak due to pain, or there is a crepitus in your hand, so it is a positive, McMurray positive. This maneuver is meant for medial meniscus injury. Then for the lateral meniscus. Lateral meniscus, fully flex the knee, then internal rotation of the leg, then varus force applied. While applying the varus force, slowly extend the knee. At the same time, you have to check the knee joint and patient face. If there is a crepitus in your hand or weak on the patient face, it is positive. It means McMurray test positive. This maneuver is meant for the lateral meniscus. Okay, say again. Full flexion, internal rotation of the leg, then varus force applied. While applying the varus force, slowly extend the knee joint. At the same time, knee joint is checked with hand, and you have to check the patient face. If weak on the patient face or crepitus in your hand, the McMurray test is positive. This maneuver is meant for the lateral meniscus. Another meniscus test is in prone position. How to do? In prone position, you flex the knee joint. Then, after that, you press and twist. You press and rotate. It is called a pre-grind test. It is meant for the meniscus injury. Then you lift the leg and then twist, rotate it. So it is called a pre-distraction test. It is meant for the collateral ligaments injury. Say again, in prone position, flex the knee, then press on the knee joint, press, then twist it, rotate the leg, rotate the knee joint. So this is called a pre-grind test. It is meant for the meniscus injury. Okay, lift the leg and rotate it. It is called a pre-distraction test. It is meant for the collateral ligament. At the same time, you can check the diseases. You can check the deformity of the popliteal fossa in back. Another test for the meniscus, but I don't want to encourage you because it is dangerous and very painful method. And ask the patient, hold on your hand, then normal side, stand on the normal side. So normal side is, so this is a normal side, this is a normal side, this is abdominal side, for example. So stand on the normal side, raise the abdominal side. Yes, bend your knee. So after that, you twist the body. You twist the patient body, or ask the patient to twist the body, rotate the body. Here, you ask the patient to rotate the body. So this is the Tesley test. It is for the meniscus. Now, normal, okay. Okay, stand on the abdominal side and then rotate the body. Now, there will be the painful, very painful. So it is very dangerous. So I don't want to encourage the students, just for the knowledge.